Welcome back, medical coders. We are jumping right into part 59 of our CPC exam series today. Now, before we dive into the deep end, make sure to like, share, and subscribe to Decode Healthcare with Arshil. Think of this explainer as your master key. We're going to decode the absolute highest yield clinical case studies across the nervous, ocular, and auditory systems.
So how are we going to conquer these incredibly complex surgical notes? We use our foolproof method, the 5-variable parsing protocol. Before you even glance at those multiple choice answers on exam day, you need to scan the operative note for 5 crucial clues. Where, which side, how deep, what exactly happened, and hey, is there a nuance? We're going to apply this exact framework right now to untangle the trickiest notes in the 6100 to 6999 CPT range.
All right, Case 1, pain management and spinal injections.
You know, the absolute critical difference between these pain management codes, it all comes down to pinpointing the exact spinal region and the injection type. Is it a lumbar or sacral epidural steroid injection, like code 64483, which actually inherently bundles the imaging guidance? Or wait, is it a cervical or thoracic facet joint injection, like code 64490? Your code selection is literally driven by isolating that specific anatomical region and joint space. Oh, and you also got to watch for sneaky clues. Is it a single injection or a continuous catheter infusion? Because that will completely change your code path.
Now, here's a crucial point: laterality. If these facet or epidural injections are performed on both sides of the spine during the exact same operative session, you absolutely must apply modifier 50 for a bilateral procedure. It's a total game changer. Just a quick aside though, depending on specific pair policies, you might actually need to use RT and LT instead, so always double check your local guidelines.
Moving right along to Case 2, spine decompression versus fusion.
When you're staring down an operative note for the spine, you've got to ask yourself one major question. Is the surgeon just taking a simple diagnostic look around, or are they performing a definitive decompression of the neural elements?
Let's actually apply that logic. I want you to contrast the decompression bundling in code 623030, which is a lumbar laminectomy with disc excision, against a spinal arthrodesis, or fusion procedure like 22551 in the cervical spine. Notice how 22551 explicitly includes the discectomy? The golden rule here, and you can't forget this, is that you cannot unbundle and code a decompression separately if it's already built right into that primary fusion code.
To survive these scenarios on the exam, you've got to be systematic. Step 1. Identify the surgical approach. Is it anterior or posterior? Step 2. Hunt for separate instrumentation. Things like rods or plates might actually be coded separately. And Step 3. Draw a hard line in the sand to differentiate a fusion from a simple decompression.
Okay, Case 3, cataract extraction and ocular surgery. Let's quickly define a standard cataract extraction. Code 66984 represents your routine extracapsular cataract removal, typically using phacoemulsification, right alongside the insertion of an intraocular lens. Seems pretty straightforward, right? Well, watch out, because this code sets up one of the most notorious traps that newer coders fall into on the exam.
And yep, here is that exact trap. Highlight this golden rule from the CPT guidelines right now. Intraocular lens, or IOL, insertion is included unless stated otherwise. Seriously, never unbundle the IOL insertion inappropriately. It's automatically assumed to be part of the whole shebang, the surgical package for these cataract codes.
Finally, we've got Case 4, ear surgeries.
Okay, here's your challenge scenario for this section. How do you distinguish between simply opening the eardrum and actually placing a ventilating tube?
Well, watch how the simple addition of a P-tube changes the code family entirely. Code 69420, that's a plain myringotomy. But the literal second a ventilating tube is inserted, say under general anesthesia, boom, you jump to code 69436. The exam is absolutely going to try to bait you on this, so never ever select a plain myringotomy when tubes are explicitly placed.
Furthermore, when you're coding middle ear repairs like a tympanoplasty, your accuracy completely hinges on highly specific anatomic exclusions. For instance, code 69631 specifically requires the absence of a mastoidectomy. You've got to always read the full code descriptor to catch these little exclusions.
Okay, let's wrap this up with a cheat sheet conclusion.
Let's lock in all this knowledge we just covered. Here's your ultimate cheat sheet for the exam. First, IOL insertion is virtually always bundled in cataracts. Second, tube placement completely changes your ear surgery codes. Third,
Always identify exact spine levels so you can differentiate fusion from decompression. And finally, be sure to check those parenthetical notes to see if imaging guidance is already bundled right into your primary procedure.
Coming up next in our series is the Big 60. That's right, Part 60. We're going to tackle radiology CPT coding case studies. Get ready to decode X-rays, CT and MRI rules, diagnostic ultrasound, and radiation oncology.
So, I have to ask, are you ready to decode the giant imaging puzzle in our next case file? Keep reviewing your golden rules, trust that parsing protocol we talked about, and I will see you in the next explainer.